Good day, and welcome to this lesson on renal and fluid electrolyte clinical pathophysiology. In the previous lesson, we talked about dehydration, fluid overload, and shock. We said that these conditions may look similar clinically. In dehydration, circulating blood volume decreases, reducing kidney perfusion, and increasing the risk of acute kidney injury. In fluid overload, excess retained fluid causes congestion. This may lead to pulmonary complications. In shock-related kidney injury, systemic perfusion fails, causing inadequate blood flow to the kidneys. As a result, acute kidney injury develops as part of widespread organ deterioration. By the end of this lesson, you will be able to identify features of major electrolyte imbalances and expected effects, interpret urine output patterns and relate them to kidney function and perfusion, recognize symptoms and signs that suggest urgent electrolyte or renal complications. Let's start the lesson by asking, which electrolytes and urine trends signal danger? Electrolyte regulation and urine output are early markers of renal stability or decline. Let's look at sodium. Sodium strongly influences fluid distribution and neurologic function. Abnormal sodium may present with confusion, seizures, and weakness or instability. Next is potassium. Potassium is most closely linked to cardiac rhythm. Abnormal potassium can cause arrhythmias, muscle weakness, and sudden deterioration. Potassium disturbances are treated urgently because cardiac instability can occur quickly. Moving on is calcium. Calcium affects muscle and neurologic function. Dysregulation may produce muscle weakness, nonspecific instability, and subtle neurologic symptoms. Urine trends. Normal urine output is 50 milliliters per hour, while oliguria refers to reduced urine output. Falling urine output often signals reduced perfusion, early renal stress, and fluid conservation. Persistent oliguria suggests progression toward renal failure. Small numerical shifts in electrolytes can cause major clinical effects, especially in older or critically ill patients. Now, how does renal failure lead to systemic instability? When kidney regulation fails, the effects extend beyond the kidneys. In acid-base instability, kidneys regulate pH by excreting hydrogen ions and managing bicarbonate. When this fails, acids accumulate. Metabolic acidosis develops. Respiratory workload increases, and cardiovascular instability worsens. Early warning signs include reduced urine output, rising creatinine, electrolyte imbalance, and fluid retention. Now, let's see some late danger signs. They include severe metabolic acidosis, hyperkalemia, pulmonary edema, and uremic symptoms. Bear this in mind. Late signs mean the patient has already entered high-risk deterioration. Advanced clinicians must identify early warning trends before these late signs appear. In summary, we talked about the roles of renal in acid-base instability, which we said that kidneys regulate pH by excreting hydrogen ions and managing bicarbonate. And when this fails, acids accumulate. Metabolic acidosis develops. Respiratory workload increases, and cardiovascular instability worsens. That is all for the lesson on renal and fluid electrolyte clinical pathophysiology. Thanks for watching. See you in the next lesson.